Now we'll discuss an ECG during temporary pacing. Temporary pacing is usually done when the indication for pacing is temporary, as in complete heart block following a myocardial infarction or a myocarditis. Sometimes it may be done prior to permanent pacing to tide over the bradycardia before a permanent pacing can be arranged. And a third reason is to support interventional procedures like angioplasty and balloon valvotomy. Sometimes when you expect bradycardia during procedure, you may put a backup temporary pacing wire with pacing sometimes or most often as a standby. This is the schematic diagram of temporary pacing. The pacemaker device is kept outside the body and the lead is introduced usually through the femoral vein into the apex of the right ventricle. Sometimes you can also introduce the pacemaker lead through the jugular vein and occasionally through the subclavian vein. Then there are certain controls like voltage output and rate at which the pacing has to be done and the sensing threshold. All these things can be controlled on the external pacemaker. We will not go into those details. This is for just a knowledge that when a temporary pacing wire is put inside the right ventricle through the femoral root, this is the track it takes and the lead is at the apex of the right ventricle. A temporary pacing catheter is stiffer than a permanent pacing catheter and has a higher chance for perforation if the person is moving. So usually you advise the person to rest in bed, and when it's a femoral root, the right leg has to be kept steady without movements. Otherwise, this lead can move within the heart and perforate the right ventricle, which has a thinner wall. This is an ECG in a person with temporary pacemaker. You can see the pacemaker spike, sharp deflection just before the QRS complex. That means it is a ventricular pacing. You can see the spikes before almost all QRS complexes. This vertical spike is due to pacing artifacts, stimulus artifact, the signal which is given by the pacemaker through the pacemaker lead. And the QRS is wide because it is ventricular pacing. You can see that there is an LB-BB pattern, left bundle branch block pattern in lead 1 and AVL. The pattern is there in V6 and V5 also, but the amplitude is lesser because the pacing is in the right ventricular apex. For the same reason, you have negative complexes in inferior leads 2, 3 and AVF. That is because when the right ventricular apex is paced, the signal proceeds from below upwards. That's why you have left axis deviation with negative complexes in 2, 3 and AVF. If the lead gets displaced, temporary pacing leads can get displaced from the right ventricular apex to the right ventricular outflow region. Then pacing, if it occurs from the upper part of the interventricular septum, this will become upright in this region. That is, inferior leads will show upright QRS complexes with normal axis, because then pacing signal travels through the myocardium from above downwards. So a change in axis in temporary pacing would mean slippage of the lead from the right ventricular apex. Normally you would expect left axis deviation with a left bundle branch block pattern for a temporary pacing. For permanent pacing also, in case of right ventricular apical pacing, it is the same. But sometimes in right ventricular pacing, for permanent pacing, you may place the lead higher up in the septum also for better conduction. Then you can see the underlying AV conduction disturbance here. There is AV dissociation. It may appear like there is AV association, but if you look at the PR intervals closely, you can see that there is variation. There is difference. This is very short, this is a little longer. So this variation shows that there is underlying AV dissociation because atria are controlled by the sinus node and ventricles are controlled by the pace rhythm. The appearance of AV synchrony in some regions is because atrial rate and ventricular rate are almost similar, almost isorhythmic. We have seen that if the QRS axis is normal in right ventricular apical pacing, that means the lead would have slipped into the right ventricular outflow tract. And usual pattern is left bundle branch block pattern because activation proceeds from the right ventricle to the left ventricle through the myocardium as in case of left bundle branch block. Now what if the pattern on ECG is seen as right bundle branch block pattern instead of left bundle branch block pattern? Then it could be of two possibilities. One is the right ventricular lead has perforated the septum and is pacing the left ventricle internally. This can occur because sometimes the myocardium there may be thin due to infarction. If you are pacing for complete heart block in myocardial infarction, anterior wall infarction, the septum may be thin and you can have perforation of the relatively stiff temporary pacing lead and going into the left ventricular cavity and pacing from the endocardial aspect. Another possibility is there could be associated right ventricular infarction, especially in inferior wall infarction, and the thin right ventricular wall can be penetrated by the relatively rigid temporary pacing electrode, and then through the pericardium it can go and pace the left ventricular epicardium. Then also there will be right bundle branch block pattern. So ECG is useful in temporary pacing patients to identify two important complications. One is slipping of the lead from the right ventricular apex to the outflow region. Then it will have normal axis instead of the left axis. And if it perforates and goes into the left ventricular endocardium, RBB pattern. If it perforates the right ventricular free wall and then paces the left ventricular epicardium, then also RBBB pattern.